Hello, I'm Bill Faulkner, and welcome to the SMRT's MR Safety Week Safety Video Podcast. This is a series of 5 short video podcasts covering a variety of topics. For the first one, we're going to talk about MR safety screening. Remember that MR safety screening should occur in Zone 2, that is outside of the MRI environment. And for safety screening, we're going to address both patients as well as non-patients. The ACR Safe Practice Guidance document says that the MR screening process and the screening forms for patients, non-MRI personnel, and MR personnel should be essentially identical. Specifically, one has to assume that any screened non-MRI personnel, healthcare practitioners, or MR personnel, and this would also include like parents accompanying children, any of these people at any given time may enter the bore of the MR imager during the imaging process. And that means, for example, a parent accompanying a child may reach up into the bore to comfort the child or hold the child. A nurse and anesthesiologist may reach up into the bore of the magnet to inject something or check an IV line or something like that. So that's why everyone that is going to be in the MRI environment in the scan room in Zone 4 needs to be screened. Now, with regard specifically to patient support personnel, for example, nursing personnel, anesthesiology, respiratory therapy, that sort of type of a job function, again, these should be identical to patients. They just don't need any of the clinical symptoms. For example, what leg is your pain in? How long have you been having headaches? That sort of thing. But everything else needs to be identical, and it needs to be documented. There are times in the past I've spoken with technologists, I've been involved in safety audits at sites, and find that in some cases, ancillary personnel or personnel who are coming in to help with a patient, and even though they're going to be there for just a short time, and maybe that's the logic, the site doesn't feel as if they need to document the screening, and this needs to be documented. If you have screening forms on file for these patient support non-MRI personnel, you need to ensure that they are current. It is a good idea, I believe, to have the person signing that document also sign that they understand they are to let someone know in MR anytime any of their medical information changes. And again, this specifically, what I'm referring to are nursing, respiratory, anesthesia. It is extremely important that these people be thoroughly screened, that you have documented screening forms on them that are thorough and complete and are indeed current. You also need to screen and document the screening of non-patient support personnel, for example, maintenance, engineering, biomed, housekeeping, security. Again, anybody coming into the MRI environment, regardless of their job duties, needs to be screened, and it needs to be documented. This is a sample screening form, courtesy of Dr. Frank Shellock. You can download this freely at mrisafety.com. I understand there are also some other languages available, but this form is extremely complete. It is extremely thorough. Some people would say it's redundant, and that is a good thing, because any of us who have been in MR for any length of time know that we have spoken with patients, and as you keep questioning them, eventually they say, yes, I do in fact have something. So this form needs to be very thorough and comprehensive. I've spoken with many sites who have asked me about, well, what about just simplifying the form? This form is complex, and every time a patient has to fill this out, they get frustrated that they filled it out before. Well, yes, it's thorough, and if you simplify this form, think about it, all you're doing is increasing the risk to the patient. This is a very important part of MRI safety. It is not something that should be looked at as simply checking off boxes. We're trying to get some very accurate history on the patient here to determine if there's anything that might be problematic from the standpoint of an MRI exam. All patients should be completely screened prior to each and every MR exam by trained individuals. And this is from the ACR guidance document. And I want to point out something here, very important, I think. Not only each and every MRI exam, but also trained individuals. I've spoken with a lot of hospitals who oftentimes have nursing personnel on the floor filling out the screening forms and that they're responsible for screening the patient. I don't think they should be responsible for screening the patient. I personally believe that it's the job of an MRI technologist or a trained MRI individuals. I remember seeing something the other day on, I don't remember if it was Facebook or the SMRT listserver, but this person was stating that the nursing personnel are equally responsible for screening a patient as are the MR personnel. I just don't agree with that. Safety is our responsibility, and we need to take it upon us to make sure that this is done correctly. The ACR says at least one screening should be by level 2 personnel. That's technologists or radiographers. Having successfully undergone an MRI procedure in the past is certainly not an indication that a future procedure may be safely performed. Again, I've talked to technologists who are getting pushback from administration saying that, well, if a patient has filled out one of these forms within the last 24 to 48 hours, there's no reason to have them fill it out again. Again, I soundly disagree with that. And this is, again, my opinion on this. This is not the way I interpret the guidelines, nor do I believe that's an accepted standard of care. My response to that is typically any patient who has had a pacemaker implanted didn't have that pacemaker 2 hours previous. So it's important that we screen our patients thoroughly each and every time, and that this be done by trained individuals. Oftentimes we get a question, well, what if you have an unresponsive patient and you have no reliable historian with the patient? Well, the ACR guidance document has a really good recommended policy and procedure for this, and I encourage everyone looking to develop a policy and procedure for unresponsive patient screening to consider what the ACR guidance document recommends, and that is that these patients be physically examined by level 2 MR personnel, and specifically you're looking for scars, lumps, bumps, whatever that might be indicative of having some sort of an implant like the chest or the region of the spine. And if there's still a question, then the radiologist may want to order some plain radiographs, or if they have previous CT or MRI studies and they have the images to review that might cover these areas of question, then that might be utilized for determining if the patient has any type of an object, an implant device. So I recommend that sites look to the ACR guidance document in developing policies for those types of patients. So to kind of summarize just the workflow here of screening and interviewing patients from an MR safety standpoint, this screening should be done again by trained individuals. The ACR recommends screening non-emergent patients at least twice. Again, one should be level 2 and should also be verbal and interactive. Now, the following is simply my opinion. I believe there are several good reasons for the technologist who is actually performing the MRI exam to be the one that screens the patient verbally and interactively, not just review the sheet with them briefly, but to sit down and go over this with them. A couple of reasons, as I said, for that. One, it gives the technologist an opportunity to develop a rapport with the patient, and it also allows them to further probe into the patient's history to see if there's anything there that might be problematic. And this also avoids issues that can occur with a handoff where someone else screens the patient and then the technologist, another technologist, performs the exam. In fact, here is an incident documented in the FDA's MAUDE database, event date dated 3/19/2015. And I realize this is rather busy verbiage here, but let me kind of briefly explain to you what happened. Patient comes into the ER. They order a CT head with contrast, and the radiologist says, well, if it would help, an MR would be more clinically warranted. And then at the same time, of course, they ordered a chest X-ray, did it about 10:30, and they noted on the chest X-ray a dual lead pacemaker. Well, then they turn around and, of course, order an MRI brain with contrast on the same day, around noon. Patient goes down to the department, and the patient is nauseated and vomiting and is unable to undergo the exam. So they send the patient up. They go ahead and admit the patient up to a room. Well, later that evening, about 6 p.m. that evening, they bring the patient back down for their MRI that was ordered that they weren't able to complete previously during the day. The technologist apparently assumed that the patient had been screened the first time, which they weren't, and they went ahead and put the patient in the magnet. Of course, the patient did have a pacemaker. Now, the patient did not have any adverse events following this, but this definitely shows what can happen in this type of a handoff situation. And the summary in this submission states that the scanning technologist failed to follow safe procedures prior to scanning the patient due to the assumption that the fellow co-workers had already screened the patient. So these are just a few suggestions, a few little reminders to think about in MR Safety Week. Take a look at your safety policies and procedures. Take a look at your screening forms. Are they thorough? Are they complete? Can you make any improvement in them? So again, we want to thank you for taking a few minutes to look at this video podcast. As I said, this is one in a series of 5. We've got 4 more to go for MR Safety Week. So I hope you'll take advantage of them. By the way, I want to remind you that there is additional and more complete safety educational material on the SMRT's website. So until next time, this is Bill Faulkner. Thanks again, and take care.